Good afternoon, members. This is the appointed time and we have a quorum. I call to order the meeting of the Bills Committee on the Electronic Health Record Sharing System Amendments Bill 2025. This is our sixth meeting. The first matter of the day, the chairperson is otherwise engaged and he will be late. So subject to your views, I will preside over the meeting on his behalf. I will now ask the Secretariat to invite the administration in. We welcome the government officials, Mr. Sam Hui, Deputy Secretary for Health, Ms. Erica Lam Bingbing, PES for Health, and the team. Since the previous meeting, the Secretariat has issued the following papers to members. First, paper CB-3 906-2025-01, list of follow-up actions arising from the last meeting. 2, CB-3 906-2025-02, administration's response to issues raised. I will now first ask the administration to walk us through the government's response. Good afternoon, members. Thank you, Chairman. Since the previous meeting, we have been following up on the issues raised by members at the previous meeting. We have submitted the written reply. I will not go into the details, but I will briefly mention several points. First, we have listened to members' views, and we will propose several committee stage amendments. Some of them are in relation to the drafting of the bill to make it more clear, and there is one substantive change. At the previous meeting, a member mentioned when an individual or an organization without authorization deliberately makes its title so that it holds out to be the e-health system. This would be an offense. So some members were concerned that the penalty level is not commensurate with the severity of the offense. Now we will now propose to raise the penalty level to a level 6 fine, $100,000. to enhance the deterrence effect and also make it more commensurate with the severity of the offense. And also, some members mentioned on the last occasion that new penalty levels were raised in the bill. So they would like to have a table presenting the changes in a consolidated manner. And also in terms of the enforcement mechanism in relation to the enforcement notice, members would like to have a flow chart to assist them to understand the workflow. This we have annexed to the written reply to help members understand the workflow of the enforcement notice. And also there are 2 points. A member has noticed that for legislation in relation to healthcare, there's different definition for minor. In some ordinances, including the legislation for protection of personal data, minor is defined as someone who is below the age of 18. However, in terms of giving, joining, and sharing consent, the age is set at 16. So a question was raised whether we need to align the definition for a minor. As we have explained on the previous occasion, for e-health, we set the joining and sharing consent at 16 years old. We have had a detailed discussion with the stakeholders. The decision was not just based on that discussion with stakeholders. Our Bureau has conducted a study on the appropriate age for a minor. So having considered all the factors, we think that it is suitable for setting the definition for minor for this ordinance at 16 years of age. Now, normally, an adult would be someone who is 18 years old. But as we said previously, there is a common law principle that for those below the age of 18, they are minors. If the decision is divergent from that to be made by their parents or guardians, their views would still be considered, despite their being younger than 18 years old. We would consider the impacts of the decision on the life of the minor and also their maturity in making that decision. So there is a flexibility to be exercised here. When deciding whether or not to receive vaccination or whether to give consent to a simple procedure, if there is diverging views between the minor and the guardians, then the healthcare providers need to consider the view of the minor. So about the consent in this context, it is just to create an account on the e-health for the patients, and also which doctors can have access to the health record of the patient. For a decision of such a nature, we think that 16 years old is appropriate because there is sufficient maturity. So based on our consultation, and also from the logical point of view I've mentioned just now, we think that 16 years old is an appropriate age. We understand that there may be worry that there will be different age threshold for different medical procedures. It may be confusing. So we will pay attention to this situation. If necessary, we will review the definition for minor in other ordinances. Finally, I would like to report to members concerning the use of identifiable and non-identifiable personal data and the relevant procedures, and also the offenses for contravening those conditions. Should we align those conditions and factors? Now, we have considered the basic difference in sensitivity of data. Under the categories of identifiable and non-identifiable personal information, and also the potential harm caused to the data owner. So we think that the original conditions are appropriate. So that concludes my reply on our response. Any questions concerning the government's response? If not, we will continue with the clause-by-clause scrutiny. We will continue to scrutinize the Chinese text of the bill. At the previous occasion, we have completed scrutinizing clause 43 of the bill. That's page 73 of the Chinese markup copy. Now please refer to the relevant page. That's clause 44. Page C1190 of the Blue Bill. Government official, please walk us through the bill. Please press the button if you have any questions. Thank you, Chairman. Now we are back at clause 44, amending section 49, page 73 of the markup copy. There are several major changes. Section 49, 1A, B, D, F, and H, we will repeal the words system and replace it with e-health system. We are also adding section 2A so that the commissioner may request body of persons specified in Schedule 5. They are regulators or professional bodies or government departments. The commissioner may require the provision of information by these healthcare professionals for safeguarding the integrity of the system. And finally, to protect the integrity and security of the e-health system, the commissioner may take any action, including removing any data caps in the e-health system that may impair the security or compromise the integrity of the system. Now, the commissioner at present already has these powers. We are just spelling out these powers more clearly to align with the future operation of e-health. If there are no questions, we will move on to clause 45, page 74, amending section 50. Several amendments here. But there will be more types of healthcare providers. So besides keeping register of prescribed healthcare providers, the commissioner will also keep a register of prescribed healthcare providers and a register of recognized non-Hong Kong public health record systems. And there are some textual changes in subsection 1, 2, 3, and 4. The register will be replaced by a register referred to in subsection 1. For subsection 3, we will repeal the register substitutes with a register referred to in subsection 1 in the e-health system, and add the word Bakkui Special Administrative Region in the Chinese version. Page 75, clause 46, amending section 51. Technical amendments, we will repeal system and replace it with e-health system. Clause 47, page 76, adding section 53A. You may recall that we will expand the types of healthcare professionals from the original 13 to cover more allied health professionals to support the growth of primary healthcare system. Now, 53A says that the commissioner may, for the purposes of the definition, may specify the healthcare provider that participates in any healthcare program authorized by the government and allow them to have access to e-health.
Page 77 of the Chinese markup copy. We have some technical amendments, including for section 56, 2D will repeal system substituted with e-health system. We will also, after section 56, 2F, add G to give an enforcement notice. And if anyone is aggrieved, they may lodge an appeal with the Administrative Appeals Board. Page 78 of the markup copy, amending section 57, access to card-based data of healthcare recipient. Let me give some background information. Card readers may be used to read data of ID cards, say names, issue dates. This is for the registration process on the eHealth system. It prevents potential error arising from manual input. We have several changes here. We are repealing in subsection 1 prescribed, substituting with relevant, and in the Chinese text of subsection 1 before 政府, we will add 特區, that is SAR, before government. We will also add in the definition of card-based data to include data that is the data of the healthcare recipient under the registration of persons regulations as well as the sex of healthcare recipient. Clause 50, amending section 58 in paragraph B, repealing system. It is substituted with eHealth system. Section 59. It is in the Chinese text. There is 特區 being added before 政府 again, SAR added before government. We are also repealing the part in subsection 3, a body corporate established by the hospital authority, etc., and substituting with NHA subsidiary because we already have a definition earlier. Next, section 60 is amended. We have non-Hong Kong healthcare professionals with this bill, and for the service of notice, we now have some changes to accommodate that fact. So in 60A2 after known address, we are adding in Hong Kong or elsewhere, as well as in B2, we are implementing the relevant change. In B3, we have address in Hong Kong or elsewhere, or instead of address. We are also adding after 60B3 paragraph 4, it is sent to the company by an electronic mail transmission addressed to the company at the company's last known electronic mail partnership. Next, we have for a partnership, we will again add after Hong Kong or elsewhere, and in 60C we are spelling out specifically it is sent to the partnership by an electronic mail transmission addressed to the partnership at the partnership's last known electronic mail address. For D, it is in the case of a body. Again, we are trying to say it would be an address in Hong Kong or elsewhere, and it is to be sent to the body by an electronic mail transmission. Next, we're adding section 60 after section 60. 60A is transitional provisions for the 2025 Amendment Ordinance. We will talk about the provisions later. Page 84 of the Chinese marked up copy. We are going to substitute section 61, and we will have a new section 61 amendment of schedules. The secretary may by notice published in the Gazette amend schedules 1, 2, 3, and 4. And these schedules are about designated health data, healthcare professionals, uploading of health data onto eHealth accounts, and the fixed penalties. The Commissioner may by notice published in the Gazette amend Schedule 5. Schedule 5 is about some registered professional bodies, and they will play a part in the system, which is why the Commissioner may by notice in the Gazette amend Schedule 5, Professor Chen Wing-Kwong. I note in the schedule they include the categories of Chinese medicine pharmacy practitioner and Chinese medicine pharmacy dispenser or technician. Right now, these two professions do not require any registration. So how will you qualify someone as being in those categories? I will go into the details when we get to the relevant schedule, but let me give a simple response here. Right now, we have some professional bodies in Hong Kong. In Schedule 1, we have some of the professions. In another schedule, we have also those registered under the accredited register scheme for healthcare professionals. So we will recognize both kinds. Some of the ones registered under the scheme do not have a particular professional body regulating them at the moment, which is why we would recognize professionals engaged by some designated institutions as those who are Hong Kong healthcare professionals. So those working at the Chinese Medicine Hospital of Hong Kong may be recognized to use e-health as necessary. We are actually fighting for registration of Chinese medicine pharmacy practitioner, and I'm actually glad to see the category being included here. That's why you need to put in place a registration scheme as soon as possible. As for Chinese medicine pharmacy dispenser, we do have a register, but it is not exactly an official register. So you have included these two categories here. This is no miscellaneous matter. If you do not implement registration schemes in future, I'm afraid there may be conflicting legislation. Thank you. For Chinese medicine pharmacy practitioner and Chinese medicine pharmacy dispenser or technician, we will convey your message to the relevant teams and see if we need to make changes. But basically, not all healthcare professionals of Chinese medicine profession can have e-health accounts. It is only Chinese medicine related practitioners working at designated institutions can open e-health accounts. Actually, it's not just them working in the designated institutions would suffice. We need to have supporting documents, say from the Chinese Medicine Hospital of Hong Kong, to have some proof of these practitioners needing to access e-health data in the setting of a Chinese medicine hospital. So you will call essentially the dispensers the Chinese medicine pharmacy practitioners. So there should be some form of professional registration in the Chinese Medicine Hospital of Hong Kong. Would you have a dispenser recognized as Chinese medicine pharmacy practitioner, or would there be more qualifications needed? I think we need to be very careful. The wording may play a key part here. I think it is something with the framework that has to be addressed. Well, it's just like pharmacists in Western medicine. It would be someone regulating the use of medicine. As for dispenser, they are dispensing the drugs. But I understand what you're saying, but you are telling me more than I expected. Say Chinese medicine pharmacy practitioner does not have a formal registration scheme at the moment. So why are you using this term here? For a dispenser alone, it should not be the case that that individual is recognized as a Chinese medicine pharmacy practitioner. I think you should be prudent, even careful here. For the Chinese Medicine Development Blueprint, we should have registration for Chinese medicine pharmacy practitioner. We do not even have formal registration for Chinese medicine pharmacy practitioners at the moment. I think Professor Chen welcomes this category being included, but I think there should be a clearer framework. I am happy about this, actually, but I am saying that you should probably, after commencement of the bill, put in place a registration scheme for Chinese medicine pharmacy practitioners as soon as possible. Well, we are actually preparing the blueprint. I think you'll rest assured later, Professor Chen. Ms. Lam, so why? I want to ask, for part 3, we are to have some designated professionals. I note in 15 there are healthcare professionals. We are right now trying to promote primary healthcare, and we have district health centers. In future, we will not only have medical social workers under 15. Would that cover other social workers? I don't think it's been made clear. Can we have more details? Well, we're actually talking about a definition. Person specified for purposes of paragraph B of definition of Hong Kong healthcare professional in section 2.1. So we would have medical social workers engaged by some designated institutions such as the HA. In their workflow, they need to access e-health data. So the healthcare professionals may open accounts for medical social workers. I want to ask, the district health centers or the district health expresses staff, they are not called medical social workers. They are called, say, case managers. So will they still be qualified to open accounts? We need to make clear who can open the relevant accounts, including social workers. Well, I think it is a question about titles. How can we have those who have different titles covered? When we talk about medical social workers, we talk about those who are in the healthcare functional constituency. In general, it would include medical social workers engaged by the HA. If there may be some confusion about the title, we will review this and introduce any changes if necessary. In fact, medical social workers are registered under the accredited register scheme for healthcare professionals. If they have a professional body in future that can deal with registration and operational matters, one can receive recognition under the scheme. I will let the Deputy Secretary supplement the answers of the PAS. I do note Ms. Lam So-Wai's question being about, for, say, district health centers, primary health care services. The operators are often NGOs or social welfare organizations. We were asked if it is the case in Schedule 3 or Part 3. The social workers will be included in Part 3. And my simple answer is no. For those providing services in district health centers, if they are providing social services, they are different from those providing healthcare services, that is, the services provided by medical social workers. I do understand where Ms. Lam So-Wai came from, however. In different social welfare organizations, it may not be the case that there is clear distinction between medical social workers and social workers. So, with these institutions, it would be depending on the circumstances who would be classified as a medical social worker. Basically, we would distinguish them based on the functions they have, whether they are providing healthcare services, related services to citizens, and they need to access e-health data. That's the key. If they provide social services, and whilst doing that, they do not need to access relevant data, they can just obtain consent for general personal data. They do not need to have an account to access e-health data. In actual operation, we'll try to make clear the distinction. But this is just a clarification that I would like to make at this point. It's not all of those working at district health centers. They would be classified as medical social workers.
感謝
Chair, I thank the Deputy Secretary for his clear explanation about the chronic disease co-care program. There are social nurses, medical social workers, and so on. Now, the social worker, as the case manager, may need to have access to certain information. So I urge the administration to consider all the existing healthcare programs run by the government. There may be the need to include social workers as a kind of healthcare professional under this ordinance. Mr. Holden Chow. Thank you. My question about the schedule is that I see dental surgery assistants, dental technician or dental technologist, and dental therapist on the list. Now, last year we passed the amendments to the dental ordinance. Now, we have defined the allied health professional in the context of dentistry. Now, these three titles in Part 3 why don't you simply use the term dental professionals? Is there any difference? Erica? Thank you. Under the DRO, there is a new category defining the relevant dentistry professionals, but the amendment has not come into effect yet. It will be sometime next year. So after the bill has taken effect, we will make an adjustment. Now we will choose, say, two categories under the category of dental professionals. For example, dental therapist, to update the definition in the EHRSSO. Now, the DRO has not taken effect yet, so we will wait for the amendments to take effect. Thank you. Dr. David Lam. Now, following up on Mr. Holden Chow's question, dental hygienist is not included. There is dental therapist, but not dental hygienist. The government has not engaged any dental hygienist, but no one can say for sure. Do you mean dental hygienist under Cap 156? Yes. The name will be changed after the amendment has taken effect. Yes, so as I said, after the law has taken effect, we will amend the definition. As we speak, the amendment has not taken effect yet. So we are still following the definition under the relevant ordinance. Now, dental hygienists are a registered profession, and they are registered under the dental registration ordinance. But it seems that you have missed out dental hygienist in part 3. Dental surgery assistant. Sorry, the speaker is coming off mic. Page 86, the third category, dental surgery assistant. Page 86, Schedule 1, Part 2, Number 3. That's dental hygienist under the relevant ordinance. And Part 3, Item 3, that's dental surgery assistant. So both professions are included. But there will be another adjustment after the DRO has taken effect. Now, Professor Chen mentioned Chinese medicine pharmacists and also other professionals working for the NGOs, which I partner to the government's program. Is it the case that the hospital authority and the government has the authority to put those professionals under any of the categories in Part 3? Now, the turnover rates in NGO is very high, so maybe there will not be enough time for you to make this classification in time. So how can you ensure that the mechanism can run smoothly? In terms of operability, especially when there are so many partners, you need to enhance the mechanism. Thank you. Now, the e-health accounts of healthcare professionals are created by the institution. For example, a doctor or a nurse working for a hospital, the hospital would create an account for these healthcare professionals. If the healthcare professionals no longer work for the same institution, then the institution has the responsibility to cancel the account and notify our office. So in initiating new healthcare professionals, we will make sure that there is an orderly system. Please continue. Page 85. Our discussion has touched upon the schedule already. Our schedule is changed to Schedule 1. The title, Healthcare Professionals, we will add the word Hong Kong before it, and there will be a new interpretation part defining the accredited register. That refers to the accredited register scheme for healthcare professions established by the government and a register maintained by a healthcare professional body accredited under the scheme. Then there are two parts under the schedule. Firstly, the original 13 types of registered professionals. And also, we will add a person whose name is listed on an accredited register. So please refer to page 86. And there is an amendment concerning a type of professional. Now, besides professionals, where there are already a registration system, we will also add Part 3. These are allied health professionals. They will have access to the e-health data, but there may not be a statutory registration system for these professionals. So if they are professionals working in institutions run by the government, then they may create a professional account. There are 20 of them, including audiologists, speech therapist, audiology technician, chiropratist or podiatrist, dental surgery assistant, dental therapist, dispenser, mold laboratory technician, orthoptist or prosthetist, orthoptist, scientific officer, medical employed by the government or the HA, bioinformatician, genetic counselor, Chinese medicine pharmacy practitioner, Chinese medicine pharmacy dispenser or technician, medical social worker, speech therapist, audiologist, dietitian, educational psychologist, and a clinical psychologist. And besides, we are including optometrists in the list as well. Page 88, Schedule 2. (26I to 26O), there were some provisions concerning the electronic documents. Now, Part 1 and Part 2, electronic medical documents, they can only be issued through the e-health system. Now, Part 2 specifies that specified medical documents can only be issued through e-health. Paper-based format is not allowed. Now, if necessary, we will introduce subsidiary legislation in the future for Part 2. Page 87, number 10, a scientific officer employed by the government or the HA. This is very, very finely defined. But I think the scope should be wider than that. Healthcare providers specified by the Commissioner under Section 53A or employed by government or the HA subsidiary should also be included. So is this definition too narrow? I take that it doesn't include one C or one B in the interpretation. I understand Dr. Lam's points. Part 3 includes professionals engaged by the government or the HA. But in number 10, we are mentioning the government again, so would that be a confusion? Now, the scientific officer grade, as we understand, this is a special position which only exists in the government and the HA. We don't see similar positions in other healthcare institutions. So in theory, that is not a contradiction. I'm just questioning how this is drafted. This entire schedule is about professionals engaged by the government, the HA or the HA subsidiary, and also those that are under Section 53A. But I think this is too narrow. I understand that this position does not exist elsewhere besides the government and the HA, but I have concern about how this is drafted. We will consider your advice. For example, someone who is now a professional under other categories, but they were once a scientific officer employed by the government of the HA. So we will consider the suggestion.
咁我哋可以翻翻
Please proceed. Let's go back to page 88 of the marked up copy, Schedule 3 for 26P to 26R. We will have some provisions relating to specified health data being uploaded to the e-health system, and it is about what kind of health data can be specified by the secretary. So we have in column 1 item, column 2 health data, column 3 period for provision of health data, column 4 specified healthcare providers. This schedule has no content at the moment. We will in future by subsidiary legislation designate the contents of the table. Next, Schedule 4. Penalty notice. As you may remember, for Section 47A, we have some arrangements for enforcing the enforcement notice. If the healthcare providers do not comply with the relevant requests or requirements to upload data to the eHealth system, they will be issued with fixed penalty notices, and they should pay the fixed penalties to discharge their liabilities. We have referred to different pieces of legislation on fixed penalty when drafting up the relevant schedule. In Part 1, we have interpretation, definitions for fixed penalty and recovery order. Part 2, penalty notice. A penalty notice must be in writing and must state that the person who has been given the penalty notice is required to pay a fixed penalty of $1,500 within 21 days after the date of the penalty notice. If the person wishes to dispute liability, the person must give the commissioner a notification. The person is required to comply with the enforcement notice given to the person, and if the person has not given any notification to dispute liability, the person's failure to comply with the enforcement notice continues. Action may be taken against the person. There is also a catch-all provision for any other related matters. Section 3. Withdrawal of penalty notice. The commissioner may withdraw a penalty notice given for an offense. If a penalty notice is withdrawn, the commissioner must give notice of the withdrawal on the person. And on the person's application, the commissioner must refund any amount paid by the person for the fixed penalty. Part 3. Recovery of fixed penalty. If a person fails to pay the fixed penalty and fails to notice the commissioner in accordance with the penalty notice, on application made in the name of the Secretary for Justice, a magistrate must order the person to pay within 14 days after the date of service of the order the fixed penalty, an additional penalty equal to the amount of the fixed penalty, and $300 by way of cost. And the notice of a recovery order must be served by sending it by post, and an application may be made in the absence of the person, and the Secretary for Justice may appoint another person to make an application. Section 5. Evidentiary certificate. A certificate is to be in the form specified by the commissioner, and it is about how the person specified in the certificate had not paid the fixed penalty, nor had they notified the commissioner that they wished to dispute liability for the offense unless there is evidence to the contrary. It is presumed that the certificate was signed by or for the commissioner, and the certificate is evidence of the facts stated of it. And Section 6. The person against whom a recovery order is made, the person is not liable to be prosecuted or convicted if the person has complied with the recovery order and the enforcement notice concerned. If the person fails to comply with the recovery order, there are some penalties involved, and the maximum penalty is essentially imprisonment. If a person wishes to review the order, they may apply to a magistrate for review. The application must be made within 14 days. The applicant must give reasonable notice. The application may be made in person or by counsel or solicitor. For securing the attendance of witnesses and generally for conducting the proceedings, the magistrate has all the powers of magistrate hearing complaint under the magistrate's ordinance. Section 8. Outcome of review. If a magistrate is satisfied that the penalty notice did not come to the notice of the applicant without any fault of the applicant, the magistrate may rescind a recovery order. If the magistrate rescinds a recovery order and the applicant wishes to dispute liability for the offense, the magistrate must give leave to that effect. After this, If the magistrate rescinds a recovery order and the applicant does not wish to dispute liability, the magistrate must order that the applicant must pay the fixed penalty within 10 days after the date of an order made under this paragraph. If the applicant fails to pay the fixed penalty within that period, the applicant must immediately pay the fixed penalty, an additional penalty equal to that amount, and $300 by way of costs. If a magistrate gives leave under subsection 2, proceedings may be commenced within 2 years after the date on which the magistrate gives the leave. If the applicant fails to comply with the order under subsection 3b, the applicant is to be regarded under the magistrate's ordinance, as this is a magistrate's order, as having failed to pay the sum adjudged to be paid by conviction and is liable to be imprisoned under that section. Page 95 of the marked up copy, Part 4. Proceedings if liability is disputed. There are 2 cases here. One, if a person has given the commissioner a notification mentioned in section 2b of the schedule, or a person has been given leave under section 8.2 of the schedule to dispute liability for an offense, and a summons in any proceedings against a person for the offense may be served on the person in accordance with section 8 of the magistrate's ordinance. If the person appears in any proceedings after having offered no defense or defense that is frivolous or vexatious, the person is convicted of the offense, the magistrate must, in addition to the fixed penalty under the penalty notice and any other penalty and costs, impose an additional penalty equal to the amount of the fixed penalty. If the person has disputed liability, but after that the person pays the penalty, the additional penalty, as well as costs, before attending court they have complied with the enforcement notice, the proceedings commenced against a person must terminate, and payment under subsection 4a must be made at any magistrate's court no less than 2 days before the day specified in the summons. The summons must be produced at the time of payment. Neither a Saturday nor a public holiday may be included in the computation of the 2 days period. And one may ask, well, the magistrate may, for good cause on application by the commissioner, rescind an order for the payment of the fixed penalty and any other order made under the schedule in the same proceedings. We have also talked about how in our response there is a flow chart for the procedures of enforcement notices and penalty notices. If members have any questions, we are more than willing to answer them. Any questions from members? If not, please proceed. We have now Schedule 5, page 97 of the marked up copy. The commissioner, as I said earlier, may obtain information from bodies of relevant professions, and we have them set out here in this schedule: Medical Council of Hong Kong, Dental Council of Hong Kong, Nursing Council of Hong Kong, Midwives Council of Hong Kong, Supplementary Medical Professions Council, Chiropractors Council, Pharmacy and Poisons Board, the Chinese Medicine Council of Hong Kong, and a healthcare professional body that is accredited under the Accredited Register Scheme for Healthcare Professions established by the government. Page 98 of the marked up copy, Schedule 6, Transitional Provisions for 2025 Amendment Ordinance. We, as said earlier, will amend transitional arrangement relating to joining consent and sharing consent. If a joining consent is given before the commencement date, the former section 7.3 continues to apply to the consent on or after the commencement date, as if the former section 7.3 had not been amended by the 2025 Amendment Ordinance. We have defined commencement date to mean the date on which section 11.1 of the 2025 Amendment Ordinance comes into operation. We have also defined former section 7.3 to mean section 7.3 as enforced immediately before the commencement date. As for transitional arrangement relating to sharing consent, if a sharing consent is given before the commencement date, the former relevant provisions continue to apply in relation to the consent on or after the commencement date. Excuse me, Professor Chen Wing-Kwong has questions. I want to ask about Schedule 5 actually. For 5, Supplementary Medical Professions Council, the SMP bill will amend the council's name to become Allied Health Professions Council. Will you amend that? Well, I don't think an amendment will be introduced here specifically. All right, please proceed. We will now go back to page 99 of the marked up copy. In Chinese, transitional arrangement relating to sharing consent, and we have defined commencement date to mean the date on which Section 6, 16, 17, 18, 19, and 20 of the 2025 Amendment Ordinance come into operation, and former relevant provisions is defined to mean Section 3 and Division 3 of Part 2 as enforced immediately before the commencement date. We will introduce CSAs to say consent is given if one has given consent after the commencement date. This should better reflect the legislative intent. Next, page 100 of the marked up copy, we have some consequential amendments. Division 1, Administrative Appeals Board Ordinance, Chapter 442. We are amending the schedule in the ordinance. There are several amendments. 1, for some names, we will make some changes. For electronic health record sharing system, we will also include in item 74 column 3 after paragraph F, add a G to give an enforcement notice under section 26R1. Next, page 101 of the marked up copy, Division 2, Private Healthcare Facilities Ordinance, Chapter 6333. There is a reference in this ordinance to the Electronic Health Record Sharing System Ordinance. As we're amending the name of the ordinance, there will be a change made. Page 102 of the marked up copy, Division 3, Dentists Registration Amendment Ordinance 2024-22 of 2024. Again, because we are amending the name of this Electronic Health Record Sharing System Ordinance, there is a consequential amendment. We will also amend the part about healthcare professionals to say Schedule 1 amended Hong Kong healthcare professionals. These are the changes of this bill. If there are no other questions from members, we have completed the clause-by-clause examination. Let me first ask the legal advisor. During scrutiny of the bill, have you found any issues with the English version of the bill? Apart from the issues raised in our letter to the administration, we have not identified other legal or drafting issues in the Chinese or English text. I'm very glad that we have completed scrutiny of the bill in 6 meetings. Many questions of public concern have been addressed. This bill is not just about storing health data. It is a key step for us to obtain more accurate information to provide better health care to citizens. We should also be able to save costs. In future, we should be able to make use of technology and data for better health care. Let me give a summary of members' comments here. I hope the administration can continue to liaise with different stakeholders, especially in those in the healthcare sector early on, because there may be some teething issues when we have the new procedures. The administration should also earmark resources for training staff in private healthcare organizations so that their work is not impeded by the new procedures. public education is also very important. Sometimes if information is entered, but sometimes it isn't, it may be a problem. We need to have public education to enhance public awareness that this arrangement is beneficial to the public. As for cross-boundary healthcare services and penalties, members have also given views on those issues. I thank members for raising different issues in the last 5 meetings and this meeting. Now, for the committee stage amendments. Can the administration talk about some of the draft amendments, or are you going to talk about them later?
Thank you, Chairman. Allow me to brief members on the contents of the CSA. We thank members for your invaluable views raised in the past 6 meetings. In our reply and also in our written reply, we have mentioned the follow-up actions to be taken. Now, besides the textual amendments, there are several substantive amendments. First, on the commencement stage of the bill, we have mentioned that we will review our technical and workflow readiness. We hope that the bill will take effect within this year. Having reviewed our position, we will set the commencement date at the 1st of December 2025, and 26C, D, G, and H, temporary suspension and revocation of recognition on non-Hong Kong healthcare providers and on Hong Kong information infrastructure. Now, members urge us to clarify the provisions. For suspension, we need to state that the suspension is based on the ground of undermining the integrity and security of the information system. For these cases, we will not allow those healthcare providers to upload information onto the system. And when the recognition is revoked, there will be an appeal period. Now, during the representation period, the Commissioner has been satisfied that there are sufficient grounds to revoke the recognition. So during the representation period, we will not allow the healthcare providers to upload or have access to the data on eHealth. Now, in terms of cancellation of registration of healthcare providers and also healthcare providers in Hong Kong, there will be appropriate changes as well. 26R1 enforcement notice. We thank members for your views. Before issuance of enforcement notice by the Commissioner, there would have been an investigation process to verify that the healthcare recipient has not stated in a format acceptable by the Commissioner that the data should not be provided to the healthcare providers. Only under these situations can the enforcement notice be issued. Now, 41A, holding out or purporting to be eHealth system and the offences. Now, the policy intent is that this is not a strict liability offence. So we will clearly state that the prosecution needs to prove the mens rea of the offender. Now, 41A(2) and 41B, purporting or holding out to be eHealth and the offence, and also using a similar title to mislead others. Now, as Sam has mentioned, having listened to members' views, we will raise the penalty level of these 2 offences to enhance the deterrence effect. It will be raised to a level 6 fine, that is $100,000 in fine. A transitional clause. If a brand new sharing consent is given, it will be deemed that a new joining consent has been given as well. Finally, technical amendments. We will amend Cap 638B to allow legal procedures arising from court procedures can be dealt with by way of electronic system. For example, summons can be issued through electronic form. So that's a summary of our upcoming CSAs. We will circulate the written documents with members and take your views further. We thank members for your invaluable views in the past meetings. Thank you. Any questions? If not, legal advisor, any supplement? Thank you, Chairman. I would like to seek a clarification. Now, I have sent a letter to the administration to inquire about Schedule 4, Section 43 about the recovery order. Can it be sent to the relevant correspondence address, but not the last known address of the person in question? Now, from the written reply, the government said that it would study the matter with the judiciary. Now, may I invite the administration to state the progress of that? Thank you, legal advisor. Now, we have discussed that with the judiciary. We will amend the provision to change it to the last known address of the person in question. The recovery order will be sent to the last known address. It will be included in the CSA. Thank you. Concerning the contents of the proposed CSA, that's so much for it. Now, members, concerning the matters to be followed up, including the CSA, will suffice if the administration circulates the papers with members. Thank you. Now, according to usual practice, if there are proposed amendments to be introduced by members, the Secretariat will circulate a notice, and only if necessary will we convene another meeting. Otherwise, circulation will suffice. If there are no other business, the meeting is adjourned. Thank you very much. 6 meetings. Thank you.